pleasure to introduce Professor Ahmet Fuat. He's recently retired as a GP in Darlington after 37 years in the same practice and 41 as a qualified doctor. But he will continue to work as a GPSI in cardiology, running a genetic lipid service for County Durham and Darlington Foundation Trust, and has also taken up a role as a medical director for Oberoi Consulting. Professor Fuat holds a number of roles in cardiovascular disease and research, including the immediate past president of the Primary Care Cardiovascular Society, and in which he was instrumental in reforming the current education and research. He has a passion for medical education and remains an active lecturer, tutor, and researcher. And it is our pleasure this morning to welcome him. Over to you.
Thank you very much. Now to try and find my slides. Oh dear. Right, hold on.
It's all right, Ahmet. We know you're retired now. It might take a little longer.
That's true. That's true. My brain is atrophying. No need to point that out, Emma. Oops. There. Can you see it now?
Yes, perfect.
Great. Well, thank you very much for that very kind introduction, Joe. Please next time, cull it down a bit, but I'm extremely grateful for your comments. So yeah, I'm a retired GP, but I took 2 months off and got bored, so I can never be idle. And it gives me great pleasure today to do this session with my friend and colleague Emma G, who's a nurse consultant in thrombosis and anticoagulation at King's College Hospital NHS Foundation Trust. I'm a GPSI in cardiology. I guess I've been asked to do this because I was instrumental in setting up the country's first community DVT pathway. So what we're going to do is I'm going to talk about DVT. We're going to use a couple of case studies, and then Emma's going to come in and talk about pulmonary embolism diagnosis and management and cancer-associated thrombosis. And please put in questions. We'll answer them at the end of both our presentations. And we may invite each other to comment through our talks as well. So you can see my conflicts there. And I have lectured for all the companies who make DOACs. So I think we need to start with how common is VT? Well, the incidence is at least 1 to 2 per 1,000. 1 in 20 people will have VT during their lifetime. I'm a bit of a medical wreck, but 5 years ago, I had pretty brutal surgery, chemoradiotherapy for tonsillar cancer, and I'm completely free now. But I developed a DVT in my leg during that horrendous treatment phase. So I do know what it feels like, and it's pretty painful. So we need to think about VT in terms of, do patients have predisposing risk factors? And those may include history of VTE, chronic heart failure, advancing age, obesity, varicose veins, myoproliferative disorders, etc., and hormone therapies, which Emma's going to touch on later, and renal insufficiency. There may be exposing risk factors such as surgery, major surgery, trauma, acute medical illness, including acute heart failure or respiratory failure, which may immobilize the patient and also increase the thrombotic substrate, and central venous catheterization can lead to this. And the two conditions that can bring these together are cancer and inflammatory diseases. And we did see a lot of VT during the COVID pandemic because we know that COVID is a thrombotic and inflammatory illness. But many hospitalized patients have one or more of these risk factors. The risk is then generally cumulative. And this is why we must try and prevent DVT. or VT in patients who are hospitalized, often bedbound and ill. We also know that following symptomatic DVT, the cumulative incidence of severe post-thrombotic syndrome is around 10% after 5 years. Most episodes occur within 2 years, and that patients who've had chronic thromboembolic pulmonary hypertension, patients who've had treated PE, 5% of them go on to get chronic thrombotic pulmonary hypertension. And we mustn't forget that if patients present to us in primary or secondary care with increasing shortness of breath and sometimes signs of right-sided heart failure. And an initial DVT-PE, particularly an unprovoked event, increases the risk of recurrent VTE, and we'll come back to discuss long-term prevention later. We also know that the risk of VT recurrence is actually highest in the first 3 to 4 weeks. And then whilst it does decrease after that, it's still a possibility that patients can recur, especially within the first 12 weeks of their event. So we're going to come on to just discuss a case history. I think it's important to point out this is fictitious, but I'm sure I've certainly seen patients like this. So Abdul is, as you can see, considerably overweight with a BMI of 48 kilograms per meter square. He's got a normal pulse. His blood pressure is high, and that needs to be followed up. He's a smoker, has an inactive lifestyle, has a family history of VT, so lots of things stacked against him. And he's just been back home to the Far East and come back on a long-haul flight, which lasted just over 8 hours. And he arrives to see you because his left leg is swollen, and there's around a 4 centimeter difference between the two legs. So I'm sure you're all aware what we would do is we'd use the Wells score, and I'll come on to see how to talk in the next slide about how NICE tells us we should action this. And Abdul will say has localized tenderness, his entire leg is swollen, and his calf swelling is at least 3 centimeters. So he has a score of 3. So what NICE tells us is that if we suspect DVT, determine the 2-level DVT Wells score, which was the previous slide I showed you. And in Abdul's case, his Wells score was over 2, so over or equal to DVT is likely. And ideally, we should arrange a proximal leg vein ultrasound within 4 hours. But NICE does say, if a scan within 4 hours is not available, undertake a quarantine D-dimer test if not already done, then offer interim therapeutic anticoagulation and scan within 24 hours if possible. If that scan is positive, we've diagnosed DVT, we go on to offer and continue treatment. If it's negative and the D-dimer hasn't been done, do it again. If it's positive, anticoagulation should be stopped and a repeat scan 6 to 8 days later, and again take action. If the Wells score is less than or equal to 1, DVT is unlikely. A D-dimer result within 4 hours or interim anticoagulation while awaiting that test result. If the D-dimer is negative, stop anticoagulation and think about an alternative diagnosis. And when the DOACs came out, and in particular rivaroxaban in my locality, because it was the first DOAC licensed for DVT acute treatment in Scotland, we followed the Scottish guidelines and we introduced a community pathway. So for many years now, our GPs have a local enhanced service. if they suspect a DVT, they do the Welsh score, they do the routine bloods, they start interim rivaroxaban, 15 milligrams PD, we ring 111 and we can get an ultrasound scan done within 24 hours, 7 days of the week. And that has significantly reduced admissions to hospital and increased our early management of DVT. So NICE says offer interim therapeutic anticoagulation for suspected proximal DVT or PE if they have a DVT Welsh score of 2 or more, and proximal leg ultrasound cannot be obtained within 4 hours. Emma's going to come back to talk about the PE Welsh score. If possible, we should choose an interim anticoagulant that can be continued if DVT or PE is confirmed. And that usually means rivaroxaban or apixaban, which don't need low molecular weight bridging for 5 days like edoxaban and dabigatran. We should carry out baseline bloods. Don't wait for baseline bloods before you start treatment. And if necessary, act on the results of baseline bloods within 24 hours of starting interim therapeutic anticoagulation. So what NICE says is offer apixaban or rivaroxaban to people with confirmed proximal DVT or PE. If either of those drugs are not suitable, low molecular weight heparin for at least 5 days, followed by dabigatran or edoxaban, or low molecular weight heparin concurrently with vitamin K antagonists, which is largely warfarin in this country, for at least 5 days or until the INR is at least 2 and 2 consecutive readings. So because we based our pathway on rivaroxaban, I appreciate there are apixaban similar studies, but just very quickly, Einstein DVT was for patients with confirmed DVT without PE. They were randomized to rivaroxaban 15 milligrams BD for 21 days, then rivaroxaban 20 milligrams with predefined treatment periods of 3, 6, or 12 months, compared to the then standard of care, which was low molecular weight heparin in the form of enoxaparin, along with warfarin. And what we found there was a significant 32% reduction in recurrent VT with rivaroxaban compared to enoxaparin and vitamin K antagonist, and no significant difference in major or non-major clinically relevant bleeding. Now, obesity is often a complicating factor, and certainly in primary care raises a lot of questions. So when I was GPSI for Darlington, big PCN, 115,000 patients, 11 practices, all on System 1. I had an advice and guidance e-consult service for VTE, AF, heart failure, etc. And it was one of the questions I often got. Should we be offering DOACs to patients with a BMI over 40, over 120, 140, 150 kilograms? What's the correct answer? And if we look at this cohort analysis from the US Optum data set, you'll see that it doesn't matter about your BMI. Rivaroxaban was still favorable in its management versus warfarin in patients, even those with a BMI of over 40. And also, there was no significant difference in major bleeding, whether your BMI was 30 to 35 or even over 40. This is an interesting study conducted at King's College Hospital, where Emma works, and it was the first registry in the UK to look at the safety and efficacy of rivaroxaban for acute VT with no heparin bridging. 97 of those patients weighed over 120 kilograms, BMI over 40. And yes, it's an observational study, but there was no objective diagnosis of recurrent VT whilst on rivaroxaban, even on those overweight patients. There were 6 episodes of non-major bleeding, no major events, and a survey at the time showed that 17 out of 22 UK hospitals prescribed rivaroxaban or DOACs in this group of overweight patients. So the results supported the use of rivaroxaban as a single drug mortality treatment for VT. The international guidelines in 2016 recommended that DOACs can be used at standard appropriate dose with BMI less than 40, weight less than 120. But for those who weighed more than that, standard doses of rivaroxaban or apixaban are among the appropriate anticoagulation options, regardless of high BMI or weight. Other drugs like warfarin may also be used, but they also suggested there's no need for drug-specific DOAC levels and suggested not to use DOACs for treatment or prevention of VT in the acute setting for at least 4 weeks after bariatric surgery, and instead in that group issue parenteral anticoagulation in the early post-surgical phase. So Abdul goes on to have a scan and he's diagnosed with proximal DVT in the common femoral vein. He's given rivaroxaban 15 milligrams BD for 3 weeks, then 20 milligrams for 3 months. But what do we do after that? Well, we've done some work to show that sadly, sometimes these patients aren't reviewed at all. They're asked to stop their treatment and are not assessed for long-term anticoagulation. And in other cases, we found patients who just continue on treatment with no assessment having been done to ask, should they continue on treatment? So NICE says that we should offer anticoagulation for at least 3 months, consider stopping treatment at 3 months, 3 to 6 months for people with active cancer after a provoked DVT or PE. If the provoking factor is no longer present, my treatment would be to give 6 months for active cancer and to consider anticoagulation beyond 3 months, 6 months for people with active cancer after an unprovoked DVT or PE, but to base the decision on the balance between that person's risk of VT recurrence and the risk of bleeding, to discuss the risks and benefits of long-term anticoagulation with that person and take their preferences into account. And I don't think we always do this in primary and secondary care, and we should. We should explain to patients with unprovoked VT and a low bleeding risk that the benefits of continued anticoagulation are likely to outweigh the risks, but always take the patient preference. So what we need to think about is, do these patients have a persistent risk factor? Do they have continuing active cancer, inflammatory bowel disease, heart failure, overweight? And we know that Abdul is 48 kilograms per meter squared, reduced renal function, or a family history. Have there been transient factors only that contributed? Are they continuing or not? So if estrogen was continuing and was necessary, I may want to continue that patient on long-term treatment. And I find the ESC guidelines useful. There are tools that you can use that give you a percentage, but by and large, to me, if it's an unprovoked event or it's persistent, then, for example, active cancer, patients should remain on treatment. If it's minor, transient, or reversible, with a less than 10 times index VTE risk, for example, long-haul flight, I would have a discussion with the patient. If there were any persistent factors, such as obesity, etc., then I probably would recommend an extended treatment. But it's a decision that needs to be taken based on the patient preference, but also weighing up the risks with recurrent VT, bleeding, and the patient preferences. And rivaroxaban and apixaban significantly reduce the risk of recurrent VT by over 80%, with major bleeding risk comparable to placebo in the extended treatment of VTE. We should attempt to reduce bleeding risk, including lower anticoagulant therapy, or rarely aspirin in place of an anticoagulant. So what do we base these on? Well, there were a couple of studies, Einstein and extension, where patients with confirmed symptomatic DVT or PE completed 6 or 12 months rivaroxaban, and they were continued on rivaroxaban 20 or placebo. And what we saw, unsurprisingly, was a significant reduction in recurrent VT with an 82% relative risk reduction. Einstein choice was a little bit different. These were symptomatic VT patients, P or DVT, where there was uncertainty about the need for extension. And they were either put on rivaroxaban 20, rivaroxaban 10, or aspirin 100. The primary endpoint was symptomatic recurrence of VT or unexplained death, principal safety outcome, major bleeding. And as you can see, both rivaroxaban 10 and 20 significantly reduced the recurrence of VT compared to aspirin, with no significant increase in bleeding. So the outcome for Abdul is, we've reviewed him. He's got a family history. He's still a smoker. He won't give up smoking. He's overweight, although we're trying to reduce that weight. And yes, this could have been an event provoked by a long-haul flight, but my treatment would be to continue him on rivaroxaban 10 milligrams daily for life. And if he had a recurrence, I would increase that to 20 milligrams daily for life as per license. Apixaban is licensed only for 2.5 BD for long-term prevention. So I'm just going to summarize here very quickly and pass on to Emma. So NICE guidelines recommend DOACs for acute VTE. The DOACs protect against recurrent VTE with acceptable benefit to risk. For the treatment of VTE and obesity, standard doses of rivaroxaban and apixaban are amongst appropriate anticoagulation options, and dose reduction is an option at 6 months for rivaroxaban and apixaban long-term. Now, just a plug for the Primary Care Cardiovascular Society, we're a community interest company. Anyone from primary or actually secondary care can join. We're free to join, have a fantastic CVD Academy where we have videos on things like VTE and lots of other areas, risk assessment, heart failure, etc. So feel free to join, and we've almost got 4,000 members. So thank you very much, and I'm going to hand over to Emma.
Thank you, Ahmet. Bear with me a moment. Okay, I shouldn't have made that joke about you being retired and taking a while to share your slides, should I? It's come back to me.
You don't worry. I've developed thick skin in 41 years as a doctor, you know.
Okay.
Thank you very much, Emma. Take it away.
Thank you, Ahmet, for inviting me to talk. on behalf of the PCCS, and also thank you very much to Joe for putting on this fantastic conference. It's always such a brilliant resource, and so valued by the thrombosis community. So I'm going to talk to you and take you through a couple of one case actually around pulmonary embolism and cancer-associated thrombosis. But before we get started on the case, just a little reminder that PE remains a very important cause of cardiovascular mortality worldwide, and it's third only to ischemic heart disease and stroke in the numbers of mortality cases across the world. And although thankfully the numbers are much smaller than ischemic heart disease or stroke, and I think that's mostly thanks to our sophisticated imaging and our rapid access to imaging now, and also the efficacy of anticoagulation, that we're able to, as soon as we're able to diagnose PE, which hopefully is rapidly, we can then get patients on treatment and know that they are fairly safe. Now, in recent sort of decades, the biggest advancements in management of PE have very much been around that rapid diagnosis of PE, and also risk stratification once they are diagnosed, to ensure that we get patients on the correct treatment pathways as soon as possible. So introducing our case this morning, this is Elizabeth. She's 46 years old, and she's got a BMI of 29 kilograms per meter squared. She has attended the emergency department. She's a little bit tachycardic, 102 beats per minute, got a stable blood pressure. She's had increasing shortness of breath over the last day. Her respiratory rate is a bit high at 26 breaths per minute. Her SATs are 95% on air, and her bloods are fairly unremarkable, except for a slightly low HB, which may be secondary to her history of heavy menstrual bleeding. She takes a combined oral contraceptive pill. I would suggest that it's fairly uncommon now actually to come across a woman of 46 years of age on the combined oral contraceptive pill. Ahmet, just to bring you in from your experience in primary care, is there a kind of strategy to ensure that patients are reviewed when they're sort of beyond the age of 35 and still on a combined oral contraceptive pill?
Well, yes. I mean, we do review patients on their oral anticoagulation. The guidelines would say that 40 or over, we should consider, if not switching to progesterone-only pills, switching to one of the lower dose combined pills. But to me, it's about the patient, and what I would say that if someone is slim, fit, non-smoker, they really don't want to get pregnant, they like the predictability of the combined pill, I see no reason not to actually use it up to the age of 50. But anyone over 35 who's overweight, smokes, has family history of VT, other risk factors, I would consider switching to the progesterone-only pill for safety reasons. So it's about a conversation and being aware in primary care rather than a blanket approach. Use a tailored approach, Emma.
Yeah, thank you. So it may well be that we do continue to see women in their 40s on the combined oral contraceptive pill. Now, the first rule or tool that we're going to apply for Elizabeth is the PERC rule, the PE rule out criteria. Now, this rule was developed in order to help us rule out PE, because we know that the symptoms are fairly non-specific and it can be quite difficult in a very busy emergency department to know what you're dealing with. So if we have a quick look and apply this to Elizabeth, if we score her 1 for her heart rate, it's 102 beats per minute. And that is all actually. Oh, no, sorry, hormone use. So oral contraceptives, she would score 2 on the PERC rule. You only need to score 1 or more in order for PE to be suspected. So that would be the case with her. And just as a side note, this rule is developed for use in people where the clinical probability of them having a PE is 15% or less, which is quite a difficult thing actually to quantify. And so I guess this can be used quite commonly, I think, in people where the diagnosis is really uncertain at that stage. So the next step would be to apply the 2-level PE well score. And if we look at the criteria here, Elizabeth has, she doesn't have any signs or symptoms of a DVT. We can say that an alternative diagnosis is less likely than PE if we consider that by this stage somebody would have listened to her chest and thought perhaps that chest infection was unlikely. It's a difficult one to apply, that one though, isn't it? Because it's a big one. It scores 3 points, and that can be the difference between a patient getting a CTPA or not. So quite a difficult one sometimes to feel bold enough to apply that one. But I think in this situation that's warranted. Her heart rate is just over 100 beats per minute, so she scores 1.5 there, and nothing else applies. So she scores 4.5, and anything over than 4 would mean that PE is likely and an immediate CTPA is indicated. Now, although fortunately we have rapid access these days to CT scans, I think that once you've done a PE well score, if it is likely, then there's a good argument for getting patients started on anticoagulation as soon as possible, providing that they're not actively bleeding. The last thing you want is to send somebody down for a CTPA and then collapse in the scanner. So looking at the NICE pathway for suspected PE, as we've already done the PE well score at the top here, and we've decided that it's likely because she gets a score of over 4, so we need an immediate CTPA with interim therapeutic anticoagulation. If the CTPA is positive, obviously we're going to go on to start continuous treatment for her. If it's negative, but we suspect a DVT, she has some signs and symptoms perhaps of a DVT, we just don't feel satisfied that that we've fully ruled out VTE, then we may organise an ultrasound scan of her leg or legs. We look to the other side, though, of this pathway. If the Wells score is less than 4, we've decided that PE is unlikely. And in this lady's case, if we had perhaps thought that she may have a chest infection, heard some crackles on her lungs and thought maybe, and let's face it, our patients aren't always neatly packaged to us. Often they come with multiple things going on. And I quite often see community-acquired pneumonia also being diagnosed when patients are admitted with a PE. So if you consider that she may have not scored 3 points for PE being the most likely diagnosis, then she may well have fallen into this pathway. And she would have then gone on to have a D-dimer test, a quantitative D-dimer within 4 hours, and interim anticoagulation whilst awaiting the results of that D-dimer test. If it was positive, she then still would have gone on to have a CTPA. But if negative, then anticoagulation could have been stopped, and the thought process around differential diagnoses continued. And NICE just sort of emphasise really that this interim anticoagulation is really important. And they suggest that we think about starting an anticoagulant that we would be happy or likely to continue if the patient was diagnosed with a thrombosis. So at that point, we need to take into account any comorbidities and contraindications, as well as a person's preferences, which is definitely important. But I think first and foremost, it's important that the patient gets on an anticoagulant and that no time is wasted on that front. So Elizabeth has a CTPA and she is found to have a segmental PE. She started on treatment. What treatment are we going to start her on though? Both NICE and the European Society of Cardiology now recommend offering a DOAC as first line. And NICE specifically recommend, like Ahmet explained in the case of a DVT, a single drug option. And for us, that's going to be either rivaroxaban or apixaban, because we can start on that drug and continue. We don't need to load for 5 days with low molecular weight heparin, as we would need to for either dabigatran or edoxaban. Now, obviously, if apixaban or rivaroxaban are not suitable for any reason, then we can consider that as an option. Or if none of the DOACs are suitable for that patient, then we can think about low molecular weight heparin and loading them on a vitamin K antagonist such as warfarin until the INR is 2, at which point we can stop the low molecular weight heparin. Thankfully, we're needing to do that less and less these days, and our first line DOAC for VT treatment at King's is actually rivaroxaban. There are some exceptions, which we'll go on to talk about in a moment, but also there are some times that we might want to kind of manipulate the choice of DOAC according to the patient characteristics that we see in front of us. Now, we quite like rivaroxaban when there is a high clot burden, because that offers us 3 weeks of the more intensive treatment up front, which we feel quite comfortable with when a patient does have that high clot burden or it's extremely symptomatic. Conversely, though, if there's a fairly low clot burden and we're worried about the risk of bleeding in that patient, we may opt for apixaban instead, with just a week of the more intense treatment. There are other little nuances as well that may direct our choice of DOAC, but I think that it's a good idea in your areas to have a first line treatment for VTE and also for AF, because it enables us to get a lot more familiarity with that DOAC and reduces the risk around prescribing and adherence as well. So like I say, one of the other nuances actually in our selection of DOAC is in menstruating women. So when before we start an anticoagulant, we will always ask a woman if she's still having periods. If she is, then we will try and find out a bit more information about that. So the frequency, the intensity of the periods, and whether they are already having an impact on her quality of life at all in terms of the heaviness of them, whether she has a history of iron deficiency anemia, whether she has any gynecological conditions that mean that she's more likely to have heavy menstrual bleeding. We will always do a full blood count to check her baseline hemoglobin before starting her on an anticoagulant anyway. But we may also go on to do some more tests like ferritin and the other hematinics if she has a history of heavy menstrual bleeding. We will counsel on contraception, and like Ahmet said, we may still be seeing women into their 40s on the combined oral contraceptive pill. And what we find often is that there is an instinct to stop that immediately because we know that the estrogen increases the risk of thrombosis. However, because we're putting them on an anticoagulant straight away, and often there are going to be an intensive phase of that anticoagulation if we opt for rivaroxaban or apixaban, if we stop that hormonal treatment at that time, there's a risk of really greatly increasing that menstrual bleeding intensity. So usually our advice will be to carry on the contraception. Of course, we also don't want unwanted pregnancies whilst they're on a DOAC, because they should not fall pregnant whilst on a DOAC. And we've got at least 3 months, so we've got a bit of time. We can tell them to carry on, and then we can ensure that that conversation happens a little bit later down the line once they're stabilised off that intensive period of anticoagulation, and then we can look into alternative options to reduce the risk of unwanted pregnancy and also to reduce the risk of that unwanted breakthrough bleeding while they're on anticoagulation. Now at King's, our first line, following some work that one of my colleagues, Dr. Jig Patel, did looking at the effect of DOACs on menstrual bleeding, is that we do a risk assessment beforehand, before we start anticoagulation, and we give patients information. We have a special information leaflet around the risk of bleeding on a DOAC, heavy menstrual bleeding, and also we have opted now to use apixaban as first line for women and not even just heavy menstrual bleeding. Any women who are still having periods will opt for apixaban as first line, as long as it's suitable in other ways. There has been some clinical trial evidence around dabigatran as well in this context. However, apixaban is generally better tolerated for patients, so we tend to go for that instead. It's also important as well to ensure that women are not pregnant before we start an anticoagulant. And in our DVT clinic, we will routinely do a pregnancy test before we do start that for women of childbearing age. And like I said, just to inform patients that they should not fall pregnant whilst being on a DOAC. And if they do, to inform us immediately so that we can switch it. So let's say then that we're going to start Elizabeth on apixaban. She has heavy menstrual bleeding. And we need to now look at stratifying her risk from this PE. So we'd look at doing a simplified PESI score, and that's what you can see here. It's simple. As you can see, the non-simplified, the original PESI has 11 criteria, and it includes their actual age. So it's a little bit more of a complicated calculation. You can find both of these on MD Calc, or you can find them easily online, and it's very quick and easy to do. The Hestia criteria is also another score that can be used at this stage, and it's really around us figuring out her risk of death at this time. And if we look down the criteria here, we can see that Elizabeth scores 0. Now, if she were to score 1 or more, she would be at a higher risk of complications of death. And just to give you a rough idea, if she scores 0, her risk of death is somewhere between 0 and 1.6% at 30 days. So extremely low. We feel quite comfortable with that. So what do we do with that information? Well, the ESC guidelines give us a traffic light system so that we can further stratify patients into high, intermediate and low risk. So if we have a look down this flowchart and look first of all to the far left-hand side, our sort of medical emergency patients, the high-risk patients in red there, anybody with any hemodynamic instability are going to fall into that category. So anybody who comes in cardiac arrest or peri-arrest, anybody with a systolic blood pressure of less than 90 millimeters of mercury, or a drop in more than 40 millimeters of mercury that doesn't have another obvious cause, such as sepsis or hypovolemia, is going to come into that high risk category. They're probably going to need level 2 care and may well be considered for thrombolysis. So how about the intermediate risk? How do we sort the low from the intermediate risk? So first of all, it's asking us to look at numbers 1 and 2. So we look at number 1, it's asking us whether there is a sign of PE severity or a serious comorbidity. So if our patient had a serious comorbidity, we would treat them differently because they've got less reserves if they were to deteriorate from their PE. But if we are assuming that there are no serious comorbidities at this stage, we'd be looking at doing a PESI score, simplified PESI, or like I say, the Hestia criteria, to classify the patients into their PE severity, either low or high. So Elizabeth is low, but we also need to think about their right ventricular function as well. And often now that's reported on CTPA as either being normal or them having some RV dysfunction. But also we may need to get an echo if that isn't reported or is unable to be determined from the CTPA to determine whether they fall into the low or the intermediate risk. So once we've established their risk, then what do we do with them? So first of all, let's take the left-hand side again, the high-risk patients. Like I say, they're going to be admitted probably into a level 2 area and be considered for reperfusion treatment at that point. They might need hemodynamic support as well. On the far right, the other sort of fairly easy category, the low-risk patients, we're quite comfortable that their risk of mortality at 30 days is very low, less than 2%. At this stage, though, we do need to think about whether we can treat them as an outpatient or an early discharge patient to treat back in the community. And as well as thinking about their risk of mortality, we need to think about other things such as their social or family situation and whether they would have easy access to medical support should they deteriorate when they're at home. And the British Thoracic Society actually go on to include in their guidelines some exclusion criteria to add to our PESI score or whatever score we're using, so that we can be confident that patients have been fully considered before we send them home. Now, within this intermediate group, it becomes slightly more complicated. So we've decided that they're intermediate because they perhaps have an elevated PESI score or they've got RV dysfunction. So then we need to go on to perform a troponin. If that's negative, then they're in the intermediate to low risk. But if the troponin is positive and they have RV dysfunction, then we're still a bit worried about them. They're not out of the woods. We're going to keep a close eye on them. And if they do deteriorate, we're going to consider reperfusion therapy quite rapidly in those patients. So this is just quite a nice way of being able to easily identify where our patients sit and therefore which treatment pathway is suitable for them. So this is the ESC guidance around outpatient treatment for PE, and it says that patients need to be carefully selected with low risk of PE. Like I say, the BTS guidance goes that little bit further and gives us some specific eligibility criteria for that. It also talks about DOACs not being recommended in patients with severe renal impairment during pregnancy and lactation, and in patients with antiphospholipid syndrome as well. So NICE also are comfortable that we now treat patients with low risk PE as outpatients. And I think that that's been a real development over the last sort of decade or two, in that this is just something that we wouldn't have considered prior to that. It would have felt quite alarming. And initially, I do remember actually, phoning these patients the following day, checking they're okay, getting them in to check their OBS, because it just felt a little bit uncomfortable initially to treat these patients as outpatients. But as we're becoming more comfortable with that, and we have the right pathways and support strategies in place, this is very commonplace now, and it's hugely beneficial to patients on many levels. So as well as the guidance around PE, the British Thoracic Society also published quality standards around the outpatient management of PE, as it was fairly new. And some of these are just quite important to pick out. And I'd already talked about the exclusion criteria, which is worth having a look at. And again, it just talks about some of the physiological factors and the psychosocial factors, which might make it a little bit more risky to send patients home. So those need to be considered. But importantly as well, I think in terms of responsibility and accountability, they state that it's really important that patients with a PE on that pathway need to be reviewed by a senior clinical decision maker prior to discharge, and ensure that that's been fully documented. Patients need to have the right verbal and written information containing details of the potential disease complications and what to do if they do develop any of those. And also importantly, they need to have a point of contact. So what they do, should they have questions or should they deteriorate in any way. Patients undergoing outpatient management should have an initial review within 7 days as well. And again, it's really important that those pathways are really robust. So the key take-home messages here are that patients need to be stratified once they're diagnosed with a PE. And if they are low risk, then we can consider sending them home. If not, then we need to think about how they're managed in hospital, whether reperfusion therapy is indicated for them. And we're comfortably using DOACs as first line for the majority of our patients now. This is a really nice slide published fairly recently that gives us a really nice prompt, I think, when we're looking after patients with PE, to make sure that we consider them holistically. And just a few things to point out that we haven't already covered are the cancer screening that we need to do at diagnosis in the cases of occult malignancy, that of course the VTE, and also I think that we're hearing a lot more, learning a lot more about post-PE syndrome now, and that sometimes there's an element of deconditioning that causes these ongoing symptoms in patients. And it's really important for the patient's mental well-being and their physical well-being that they get back to physical activity as soon as possible. Also, patients are interested in when they can travel quite often and might have questions around that. And it's important that we address those early on, because you do hear of these myths of people never flying again because they're so worried and think that that's out of the question for them. So Elizabeth was, like I say, at King's we would actually start apixaban because she's still menstruating. But in the case of this study, she was started on rivaroxaban, 15 milligrams BD for 21 days, and then converted to once daily 20 milligrams. And she had her initial review within 7 days, according to the BTS guidance. Now, sadly, Elizabeth went on to be diagnosed with breast cancer 3 months later. She was still on her rivaroxaban. It was stage 2 breast cancer. Her treatment was a lumpectomy and chemotherapy. We know that this is extremely common and that patients with cancer have a 5 times higher risk of developing cancer, and that cancer accounts for almost 20% of all VTE cases. It's very complex, it's multifactorial in terms of its etiology, and there are patient, tumour and treatment-related risk factors. We know that certain cancers carry a very high risk of thrombosis, and it's important that when patients are diagnosed with cancer, they're told about that risk of thrombosis so that they can be vigilant for symptoms and present early. Also, a lot of patients may come with comorbidities and other risk factors that increase their risk of VTE, such as prior VTE, that we need to keep a particularly close eye on. And of course, a lot of what we do to patients when they have cancer further increases their risk of thrombosis. So looking at the treatment options, obviously low molecular weight heparin used to be the mainstay of treatment in cancer-associated thrombosis. But now we're much more comfortable to use DOACs up front. And you can see from this meta-analysis across 3 of the DOACs, rivaroxaban, edoxaban and apixaban, that actually the efficacy in VTE recurrence was very good compared to low molecular weight heparin across all of the DOACs, and that there was no statistical difference in major bleeding. However, the risk of clinically relevant non-major bleeding was higher with DOACs, and that was primarily around mucosal bleeding. So these patients need to be carefully selected, and we would avoid using DOACs up front in patients with GI or GU cancers or anybody with any active bleeding. A plethora of guidance has been released over the last few years internationally, and they're fairly aligned, and you can review those there. But all of the guidance are happy and comfortable to use DOACs as first line. But this is a nice novel study by Professor Noble that really looked at what's important to patients when they start treatment for cancer-associated thrombosis. And the main thing that this says to me, the cars actually represent how far a patient would travel for certain attributes of their treatment. And what it really represents to me, you can see down here between the 30 miles and the 119 miles is actually, the difference there is being able to have a tablet form. So patients would travel sort of nearly 100 miles more in order to have a tablet. And then as you go up, you can see there that there are sort of minor gains in some other attributes, such as not needing INR control and not having interactions and having a once daily tablet. So obviously, we need to bring in patients into these decisions, let them know what the options are, take into consideration their individual situation, and discuss with them what they feel most comfortable with. We want them to adhere to their treatment. They're likely going to need to be on this treatment for some time, so that's really important. At 6 months, she's had her lumpectomy. She's still on her chemo and still has active cancer. Therefore, we will continue the rivaroxaban for as long as she has that active cancer, or for as long as she's on cancer treatment. And the guidelines are fairly unanimous in agreeing that the treatment does need to continue for patients with active cancer beyond 6 months. So she continues on rivaroxaban in this case for the duration of her active cancer. So we know and feel comfortable with using DOACs both in the setting of cancer-associated thrombosis in selected patients. And just to add as well that we need to look at their chemotherapy regime to make sure that there aren't any interactions with chemo in their DOACs before we start that. And also, in recent years, we've come a long way in treating patients with PE as outpatients and feeling very comfortable with that now. Like I say, there are huge benefits in patients being able to get back to their normal lifestyle much, much quicker, reducing the risk of that, of patients becoming deconditioned and picking up other things whilst in hospital as well, such as COVID. So thanks for listening. Really appreciate you turning up this morning.
You have stopped screen share.
Sorry, that's my friend. And I can see that we've got some questions.
Yeah, thanks very much, Emma. That was a fantastic presentation, covered a lot of areas. So we've got 5 minutes. And if I could just answer a couple very quickly, get them out of the way, and then I'll come back to you, Gemma. Dr. Ramadan, I don't know what you mean by DOACs needing loading or bridging. So if we think about atrial fibrillation, you just start on the dose, there's no need for bridging, and they work within 12 hours. In terms of VTE treatment, then you need the higher dose for 1 to 3 weeks, depending on the drug you're using, before you then go down to the lower or maintenance dose. So I guess that may be what you're talking about. And the other thing is, how would you define a long haul travel? Well, I would say 8 hours or more, wouldn't you, Emma?
Well, I think it's a bit arbitrary. We often use the 4-hour cutoff, but like I say, I don't think there's any evidence for that I'm aware of. I think that's a fairly arbitrary one. And I think that once your patient has had a clot, generally speaking, we can offer thromboprophylaxis for any long haul flights over 4 hours in the future, because it's easy to do now with DOACs, just to give them reassurance and protection against any future thrombosis.
Absolutely. So that's great. And there were a couple of questions, I guess, about cancer screening. And NICE used to say screen all these patients with unprovoked. But what would so there were a couple of related questions. There were one that said, with men of a certain age, a PSA should be done for VT with no risk factors. Is there any evidence to suggest any cancer screening in women? So do you just want to answer those general questions?
Yeah, it's really important. We are still picking up occult cancer, and it can be the first sign a patient has that they have cancer. They may have no other symptoms at all. So our approach at King's is to do a chest x-ray still, even though that's not strictly necessary anymore according to the NICE guidance. We also will look at bone profile. We will do a PSA in men and calcium, because they're fairly easy to add on to the bloods and can be really useful. We'll do urinalysis, and we will also do a thorough screening with the patient verbally and ask them about red flag symptoms such as lumps, bumps, coughs, bloating, altered bowel habit. And actually that's been really useful sometimes in picking up things that we'll go on to them do further investigation for. So yes, you're right, definitely I would do a PSA, definitely for men over 40 with an unprovoked clot. It's easy to do. There aren't any additional blood tests for women. We don't do the tumour markers for women. We used to do those, but we don't do those anymore. But yeah, I think certainly a detailed history, and NICE do suggest also an examination. We perform an abdominal and lymph node examination for those patients as well. And we are still picking up an occult cancer rate of around 3 to 5% in these patients. So it is important that we do have those thought processes, I think, and go down that pathway.
Yeah, absolutely. And just a practical one from Rachel. Just wanted to bring up D-dimer use in Wells score DVT greater than 2, often impracticable to do in a short time. And so interim anticoagulation used, especially out of hours without this test. What would your reflections on this be? Well, yeah, absolutely. If you do a Wells score, it's 2 or over, you start interim anticoagulation as per NICE, and then do the D-dimer when you can get it, if it's not possible. Obviously, as soon as possible, but most areas, I would think you can do a D-dimer and get a result very quickly. We certainly can. So we don't use point of care, which we find not very helpful.
Oh, yeah, NICE say we can use point of care as long as it's quantitative.
Yeah, it has to be quantitative.
Yeah. The problem is you don't want to then send a venous D-dimer sample after you've given anticoagulation, because of course it will impact on that. So if you can't get the result, at least try to send a venous sample if you don't have access to point of care testing before you give that anticoagulant.
Yeah. I mean, we've reached 10:30, and there are a few other questions, but I'm afraid we can't really answer all of those. We need to go on to the next session. So I'm just going to thank you, Joe, for inviting us, the PCCS, to present. For those of you who weren't there at the beginning, PCCS, free to join, Primary Care Cardiovascular Society, really good website with lots of CVD Academy videos, including those on VTE. Thank you very much, Emma, for agreeing to help with this PCCS session. Always a pleasure working with you, and I'm sure we'll work together again.